afternoon. Welcome to Medicine and Society. My name is John Lantos. I'm standing in for Rosie Tong, who couldn't be here today. We are going to talk today about some difficult issues of conscience in medicine and when doctors can refuse to provide treatments under certain circumstances to patients who want them. I am a pediatrician and bioethicist from the University of Chicago and the Center for Practical Bioethics in Kansas City. And I'm joined here by two doctors from Charlotte who will introduce themselves.
I am Irene Zink. I'm with the Department of Family Medicine, obviously a family physician. I'm the Associate Program Director with the department, and my specialty area is urban underserved medicine.
And my name is Dr. Theresa Sunderland. I'm with Presbyterian Hemby Children's Hospital. I'm the medical director of PIPS and the chairman of pediatrics there. And my specialty is pediatric critical care.
So the big question, I think, is there ever something a patient would ask you to do that's legal to do, but that you would refuse based on your own conscientious beliefs?
There are so many different things in medicine that can be controversial for individual physicians to deal with, whether it's their religious beliefs or their own personal beliefs. Mm-hmm. My thought is that above all, do no harm to the patient, and to also be an advocate for the patient. There's controversial issues like birth control, the morning after pill, which Plan B was just, approved for 17-year-olds and up, physician-assisted suicide. There's lots of different subjects.
Let's start with birth control. Are there any circumstances under which you wouldn't give birth control to a patient?
The only instance that I wouldn't do that is if it would be harmful to the patient.
So let's say a 12-year-old comes in and you ask the parents to leave the room because that's what adolescent docs recommend, and she says, me and my boyfriend, we're very much in love and we've decided to go all the way. Could you give me a prescription for birth control pills?
Well, that is very hard because of her age.
Sure.
But what would be worse? A 12-year-old who is having unprotected sex and ends up pregnant?
Yep.
Or a 12-year-old who is having unprotected sex on the birth control pill and doesn't get pregnant. There's so many different issues that you have to discuss with that 12-year-old. Mm-hmm. First of all, you would really want her to be talking with her parents, and you would want them to know. But there's also...
But you've promised her confidentiality,
exactly.
Right?
Her confidentiality was what I was just going to say. But the thing that you have to think about is educating this patient about her decision. The other thing is this her choice? Is she being pressured into it? With my patients, I always like to teach them and educate them that it's their body. So it's what they want to do with their body. But that they have to be smart in what they're doing with it and protect themselves, especially from sexually transmitted diseases and getting pregnant. Mm-hmm. In her case, I would prescribe the birth control with very lengthy talks and education. I would also bring her back. I would encourage her to bring her boyfriend in. I would also encourage her to talk with her boyfriend more about these issues. Is this their first time together? Has he slept with anyone else? How old is the boyfriend? That's a big issue too. Uh-huh. I mean, if he's over the age of 18, that brings in many, many other factors and legal issues.
Yeah. What do you think?
I'm in total agreement with you. I would definitely prescribe it, and I think we are bound by confidentiality unless she would harm herself. Or
I'm not so sure I would. I think a 12-year-old having sex, I'd have a lot of trouble simply prescribing that without informing her parents. I'd try to get her agreement that talking to her parents was a good idea, but if I couldn't, I might send her to someone else and say, I just can't do it. Do you think
so
a doctor who behaved that way would...
when she came back in 4 months and she was pregnant at the age of 12 and a half?
If that happened, I would feel terrible. I wouldn't be completely confident that prescribing her birth control pills would prevent that, since I'd worry a little bit about the judgment of a 12-year-old. either making a decision to start sexual activity or to continue to take a birth control pill every day. So I think I'd want to know a lot more about what was going on both in her family and with the boyfriend before I'd feel comfortable doing it. It would mean imposing my values, but I think whatever we do, we impose our values, whether it's by giving people permission or by restricting what they do.
So are you saying that our values are like, you're 12, go have sex?
I think you are certainly giving permission for that. I'm not sure you're endorsing it, but I don't think you're making a value-free decision.
Mm-hmm. And I appreciate what you're saying. And, you know, if it was my 12-year-old, I'd have to think about what, you know, what I would think, but I would hope that there'd be open conversation there. And you said some very important things that I appreciate, and that is, if you couldn't do it, then you would send her to someone else.
Right.
The other thing that you brought up is talking to her parents, which I think both you and I would feel the same way. But, you know, confidentiality is an issue. And you also have probably, I'd like to think that this is maybe a patient that we had been seeing for some time, maybe,
That's
through
an
the
important
years.
issue.
That's another issue, too. And
Definitely that would have follow-up with.
exactly. I mean, I don't think either you or I would give her the birth control prescription and say, hey, see you later, take care. Usually I will bring them in in like about a 2-month to 3-month period of time to make sure to see how they're doing on the pill and just review kind of all the educational things and see how they're doing just with their decision in life.
Mm-hmm. I mean, another area where issues of conscience tend to come up is not so much the beginning of life, but the end of life.
Mm-hmm.
In this country today, there are 3 states where physician-assisted suicide is legal. If it was legalized in North Carolina and one of your, let's say, adult patients came to you and said, Doc, I want you to give me a prescription for enough medicine to kill myself, what would you want to know before you wrote that prescription? Or would you write it at all?
I could see myself writing a prescription for that. Some of the things that I would be concerned about is specifically what is their illness? Is it terminal? Assess their pain levels. I would like to have family members involved in those discussions. And also it would be important to have hospice care and support with this person when they decided to take the medication. I would not feel comfortable just handing something and sending somebody home with that, but I think there needs to be a very close network of persons with them.
So the idea of assisting someone in suicide is not morally repugnant to you as long as it's done in the right circumstances with the right support networks in place? Is that,
yes.
Yeah.
That's my opinion.
Yeah?
Mm-hmm.
How about you?
Well, it's a big issue, and it's something to think about, and it really depends on the patient and the patient's circumstances. You know, daily, when you're carrying on the hospital service, you know, there's many patients that are at the end of life, and you're making decisions on their care daily, even hourly at some places or points. And I think it's a conversation that you would have to have with the patient and with their family. You know, it would totally depend on the patient's illness and prognosis. Of course, I'm not going to just give a prescription to assist someone to die who's just, you know, hey, I'm 80, I've lived a good life, and I'm ready to go. You know, I really don't have anything to live for. My wife has, you know, died. My kids have all moved away. That would not be a reason. But if I had a patient who had metastatic lung cancer, really, you know, was having difficulty breathing, having difficulty getting around, the quality of life was not there, then definitely it's something that I would do and consider. Only after, though, a conversation with the patient, if the patient was lucid and able to make decisions, and if not with the patient, then with the family.
Yeah, it gets much harder if the patient's not lucid. Even in Oregon and Washington, only a competent patient can request this. Families can't ask for lethal medication to kill their family members. So that would be one limit that most states would put on it. But it is interesting that you're sort of figuring out the criteria that you would apply to decide when it's permissible or not, rather than letting the patients decide. If your 80-year-old just said, hey, I've lived a good life, all my family's gone, I'm lonely and I'm ready to go, you'd say no?
Then I think that I would be taking the position of playing God almost.
Well.
Because, I mean, and then this brings in the whole religious aspect, but, you know, if it wasn't in God's plan, depending if you believe in a higher power,
right,
that it was his time to go, to assist him in dying by giving him a prescription, you know, aren't we playing God in a way?
Well, at least we're invoking our own consciences and our own beliefs about what's permissible or not permissible, and saying, I can go this far, but if you ask me to go farther than that, I have to draw the line. I couldn't do that. Whether you'd condemn a colleague who did it or not would be a different issue.
What about?
Condemning a colleague? I definitely would invoke my right to the length that I went to, such as I'll draw the line here, and I'm not going to help the 80-year-old who is just tired. And but I forgot what you said. I'm sorry.
One of the interesting things about the data from Oregon, where physician-assisted suicide has been legal now for 10 years, people have studied the patients who come to doctors and ask for prescriptions. They can't study the people who have filled the prescriptions and used them, obviously, but of the people who ask, some of the reasons that everybody thought would motivate decisions did not turn out to be the ones. That is, most people who asked for a lethal prescription did not say it was because they were in intractable pain. In fact, most people said, one, I'm lonely, and two, I fear being a burden on my family. Those were the two main reasons why people did it, which raises some interesting questions about whether helping people kill themselves would be one approach versus trying to hook people up with social support, churches, groups of friends, getting them a puppy might be
I mean,
a way of approaching this.
I have to say, I work in an urban underserved clinic for Carolinas Medical Center, and, you know, there are a lot of patients that I see that, you know, are at the end of their line, especially with the economy the way it is now. I mean, was in private practice for 5 years, and I'm now seeing patients who I was seeing in private practice who had a great job and had insurance, and here they are coming to a clinic for sliding scale.
Can you think of a particularly tough case without violating anybody's privacy?
You know, an elderly patient in his mid-70s who is depressed, really doesn't have anyone in his life, doesn't have a good relationship with his children. I haven't been approached, you know, and asked to be given the prescription, but they just feel like there's nothing more to live for. I'm ready to go. And in this patient's case, there was some a medical problem that he was having. I've been trying to, you know, not do any HIPAA, but he was having hematuria. But he had chosen that he didn't want to work that up anymore. And, you know, I felt with him that if that was his choice, it was his choice to refuse further medical workup for that. But if he had come to me and said, you know, all those things that, okay, well, I'm just ready to go on and die, I would not give him a prescription to do that. So, but when he would be expressing these things to me, obviously he was depressed, so we address the depression. We try to address things that he can do during the day that can make his life more enjoyable and that he can find the quality in it again.
Right. Can you think of any recent cases you've dealt with where you've felt a conflict?
Many. Being in the ICU,
I'll bet.
we have to deal with that continuously. I have never had anybody outright ask me for a prescription to have assisted suicide. We do have cases where children are terminally ill, and most of our instances are that you try to withdraw or limit treatment rather than just give medication, and then you have to give medications to treat and make sure that they're comfortable, pain and sedation, if you were to limit treatment or if you were to withdraw. And there is a question as to how much you need to give them, and a dose that you're not quite sure if it would be lethal or not.
So just to be clear, sometimes trying to control pain and suffering seems to cross a boundary to hastening death?
Yes, definitely. And I think it's a very fine line, and those are tough. Those decisions are tough.
Have you ever had situations where parents have asked about whether their child could be an organ donor and they were not brain dead?
No, I've never been in a situation.
Those come up sometimes. But it sounds like, as we're talking about this, we all have situations where we would draw a line. We would respect patients' requests up to a point. We think patient autonomy and their right to make decisions for themselves is very important. But there's some boundaries where we'd have to just say no. Is that?
I feel in making some of those decisions, the longevity of life for that patient, such their diagnosis, their illness, and also how much pain they're in, what supports they have, tend to help make those decisions and give you an idea.
Have you had situations where parents asked you to stop treatment and you thought the prognosis was so good that you couldn't respect that request?
Yes. And I will draw a line there too. If I truly don't think something is terminal, I could not bring myself to. I can, if somebody has a chronic illness, and such as children that have neurologic disabilities, they tend to aspirate and get pneumonias, and your child gets older and they have more and more pneumonias, and you can see that this child is on a path to where they're going to get sicker and sicker, and they spend more of their time in the hospital than not. Right. Where you do decide maybe with a parent that you don't want to treat the next pneumonia, but make them comfortable. And that's kind of a different way of approaching things, rather than just giving a prescription to end things. And it's almost like letting the natural course happen without intervening.
Yep. And the decision not to treat.
Right.
Let me change the topic a little bit since we just have 10 minutes left. One case that was in the news a lot recently where people thought the doctor should have just said no involved Miss Nadia Suleiman, a woman in California who gave birth to octuplets. Do you have any thoughts about that case?
The octomom.
The octomom.
I definitely
should the doctor lose his license?
That's an interesting question.
Yeah, very.
Or how would you analyze that case? Where do you see the ethical issues?
I'm not so sure I could comment on his license, but ethically, I think he did reach out of bounds. He went beyond the standards of care, although they're not deeply ingrained in our society, but there's some guidelines out there, and he did go above and beyond this limit that we have.
Recommended by his professional society.
And also, I wasn't there when he made the decision, but
no, there's a lot we don't know. Yep.
From our perspective, did not investigate fully how this mother would care for these children, and even having those children, being pregnant with 8 could cost you your life. And
from what I understand is, she has a total of 14 children, and I believe that the physician assisted her with getting pregnant with the total of the 14. 6. And I think this comes back down to the physician doing no harm. In caring for a patient, our prescribed treatment or the treatment we provide, is it going to harm the patient? Is it going to harm anyone else? I'd have to think about the fact that, okay, so I am giving this mother 14 children.
Right.
What is the life going to be like for those children? What are her support systems?
Not so much harming his patient, but harming
the children.
The children who would.
And I mean, 8 children, or what do you call them? The octuplets.
The octuplets.
They had a very fortunate outcome. I mean, usually a pregnancy of 8 is not successful.
Right.
I haven't heard much lately about if there, and I don't know if you know, if there's been any of their, growing or developmentally disabled.
I haven't heard much follow-up. But let me just push you a little bit. What if a woman said, I want you to transfer 3 embryos?
Okay.
So I can have triplets. That would also place her at some risk, and the children would be at higher risk of being born prematurely with all the problems that should cause. Should a doctor just say no at that?
I kind of always go on my fallback is, would this be a natural thing?
Mm-hmm.
And having 3 babies at once and having triplets is not, it is natural in some cases, but it's extraordinary. Not many people have triplets.
Mm-hmm.
So to do that with the intention of having triplets, no, I would not agree to do that.
Sounds like by those criteria,
Mm-hmm.
you'd have to ban all in vitro fertilization, since
No.
that's pretty unnatural.
Well, you do have a point there, but
Maybe infertility exists for a reason.
That's interesting to bring up because, you always think about that. But and then you have to think about the parents out there that are having children, then that's a whole nother ethical or judgmental issue,
Okay.
whether who's going to be a good parent and who's not. What you do have to think about, though, is the mom who's coming to you, whether she's a single mom or a married mom who wants a child.
Mm-hmm.
But when they're coming back for the 7th time for in vitro fertilization, and that's where I think, it's not our place to say you can only have this many children. We're not living in China. But you also have to take in part what is going on in that person's life. And
now I'm a little confused. You're not supposed to say you can only have this many children, but if she comes back for the 7th time and has 6 children at home under the age of 7?
Well, the other thing is she wasn't a working mother, and that's another
so
judgmental
she's not going
thing.
to be able to take care of them. Should the doctor just say no?
I think that in that case, you do have the right to say no.
Okay.
And then you can say, but, it's a free world, or we're a free country. If
You would refer them to somebody else?
And it wouldn't be someone else, that would just, I would refer them to someone else who would consider possibly doing that, but also look at the whole picture.
Sure.
So, because I really think in the long run, it's those children that are suffering.
Right.
And I don't know what favor we did for her besides now that she has a face that's known all over the world.
Well, the publicity is a whole different
Mm-hmm.
issue, and whether that did anybody a favor or not is difficult to tell. It seems like a theme, though, in all these cases is that we're trying to do as conscientiously as possible what we decide is best for our patients. And in seeking that goal, we try to listen as hard as we can to what they say they want. But sometimes we decide that what they think is best for themselves is not what we think is best for them. And sometimes when we feel that way, we don't agree or don't abide by their wishes. Is that how conscience works for you in your practice?
It does. And I think Dr. Zink had a good point. If this person were to come back for the 7th time and you don't feel comfortable, I think we kind of owe it to our patient to help them get another opinion. If this is something that they really think that they need, I think it's fine to refer them out. And I think it's kind of our duty to do that too.
Although it seems like you'd hope that most doctors would share the same conscientious concerns that you would, and it would be hard to find someone who would accept such a mom and referral.
Well, when you refer, not necessarily to somebody who would do it,
Okay.
just another opinion and another physician. So,
Maybe with repetitive opinions, they would understand where you're coming from. But I think that any physician, you would hope, would practice with conscience.
Yeah.
How they define their conscience and what their beliefs are individual for each physician. And I think in talking, the three of us, we all have found out a little bit more about our conscience in medicine and what we would do. But it's also, I think, something to learn of, you know, when things like this come up, let's talk about it. Talk to your colleagues about it.
Yeah, and I think the big controversy on the national stage where, as you may know, President Bush had enacted a broad protection for physicians and other health professionals who invoked conscience claims in order to refuse to do certain things. By that guideline, pharmacists who refused to fill prescriptions for emergency contraception would be protected and couldn't be fired. President Obama overrode that or repealed that directive, and it's been thrown back, I think, to the states and the courts to decide. So I think we're going to be hearing a lot more about the controversy, about the limits of conscience, and when individual physicians can just say no, and when the state or other regulatory agencies or even hospital administrations will say, no, if you're going to work here, if you're going to practice here, this is part of your job. There's certain things you need to do, and that may include things like prescribing or dispensing emergency contraception.
At least advising and educating patients, helping them to make the best decision on their treatment.
definitely.
Or referring. And,
exactly, if you can't provide the care that they're looking for.
And I would hope that's something almost all physicians would agree upon, that at least giving patients information so that they can make decisions for themselves, even if we refuse to do certain things, is a professional obligation.
Mm-hmm. Above all, do no harm to the patient.
Okay, well, it's been great talking about various conscience issues in medicine. As I say, Rosie Tong couldn't be here today, but we hope we'll be back for the next show. I'm John Lantos. Thanks for watching Medicine and Society.